Hi, everyone. It's Katie with Ria Health, and I'm here today with Dr. John Mendelson, researcher and physician in the field of addiction. And today we're going to pick Dr. Mendelson's brain about the medication gabapentin for alcohol use disorder. So first, thank you for taking time to speak with me today.
It's always a pleasure, Katie.
Great.
My brain is getting smaller with each visit.
Always appreciate your sense of humor too. Sorry to hear that. So just to begin, can you tell me more about gabapentin and how you use it in your practice for alcohol use disorder?
Sure. Gabapentin is an interesting drug. It was introduced, 20 plus years ago as a drug to treat epilepsy, to treat seizures. And it was very safe. It's well tolerated. And people rapidly discovered that it had a bunch of other potential uses. The company that made the drug initially promoted those uses, those off-label uses, and ended up in a lot of trouble because they didn't do studies about that. So it got a very bad name with them named Neurontin. But nonetheless, some studies over time have shown that gabapentin is useful in treating chronic pain, and reducing the amount of opiates people need, and treating something called restless leg syndrome, which is a problem at night where people are moving uncontrollably. They often kick the bed sheets off. And there have been a couple of good studies showing it's effective in alcohol use disorder. The main study was published by a woman named Barbara Mason at Scripps Institute. And she showed that doses of 900 to 1,800 milligrams a day of gabapentin decreased people's days of heavy drinking. In other words, so when they days they were drinking, they drank less, and decreased the number of drinking days per week. So they had both decreased days of heavy drinking and decreased drinking days per week. And they compared it to placebo, and it was effective. Other studies have not confirmed those results, but so her study stands as the best out there. And other studies have used slightly different versions of the drug and not been randomized. So many of us still feel it's a valid study for which to base treatment on. What's interesting about gabapentin is that it's been used in a lot of pain patients, and there's been concern in some states that people who use opiates are moving to gabapentin instead as a drug of abuse. And there does appear to be a small population of people who overuse gabapentin, but given the number of prescriptions written and the number of patients prescribed the medication, it seems like a very small problem. And it's also in this population of people who abuse almost anything. So anyway, so that's sort of the summary of gabapentin. Other reasons that we doctors like it comes in a variety of dose units and strengths. It does not have any drug-drug interaction, so it's safe to give it with virtually any other drug, and it's inexpensive. So although it's a generic drug, and a month's supply costs like $15 or something.
Oh wow!
It's pretty good. So that's the background of gabapentin. You asked how do we like to use it at Ria, and what's our Ria strategy? So there are two basic places where gabapentin fits into the medication treatment armamentarium we have. First, I should also tell you that going back a little bit, gabapentin also has been tested in anxiety disorder and some studies have found it to reduce anxiety. And it's slightly sedating, and some studies have found it helps with sleep in general. So where does it fit in our treatment armamentarium? Well, first off, many of our patients have anxiety. Right? Anxiety disorder. And gabapentin appears to be really good in those patients because it tackles both the anxiety and the alcohol desire issues. Second, many of our patients have sleep disturbances. So patients, classically, when people drink more than they should, they wake up at 3 or 4 in the morning and or have trouble falling asleep as well. And gabapentin can really help improve people's sleep. Okay, so if patients, if you're one of our patients and you call and you have you have anxiety all the time, and you're considering taking more Valium or more Klonopin or more Xanax for that, I think gabapentin is actually a very good alternative in those circumstances. The last thing that makes gabapentin an advantage is that it can suppress withdrawal symptoms and suppress withdrawal severity. And in some hospitals, gabapentin has been used to treat alcohol withdrawal syndrome. So if again you're drinking a lot and your drinking is, you have shakes and tremor and whenever you stop, and you have you have anxiety and insomnia, gabapentin is your drug, at least for a first line. So that's how we use it at patients. It's often a first line choice, particularly people at risk for alcohol withdrawal syndrome, who have anxiety and insomnia. It's also good. The final advantage of gabapentin is that we have some patients who are on opiate pain relievers. They're on Vicodin or Norco or Percocet, or oxycodone or something. And those patients you can't treat them with naltrexone. Naltrexone is contraindicated in those patients. So gabapentin is a great choice for patients on opioid therapy already. Okay.
Okay, great. That's really helpful. It sounds like it's a medication that can be used for a diverse amount of issues that people are having. Awesome. So I guess next to that, I'm just curious, in your experience in treating people with alcohol use disorder, about what % of the patients you treat use gabapentin for alcohol use disorder?
I think about 30 or 40% of the people we're treating get gabapentin. It's often, in Ria, I think our first line is still naltrexone if possible, but again, we have patients who just aren't going to qualify for naltrexone because of their concomitant opiate use, and prescription opiate use. And so 30 to 40% get gabapentin at some point.
Okay. And do you ever prescribe it then alongside naltrexone?
Absolutely. Absolutely. It's a fantastic, again, for the patient at high risk of alcohol withdrawal syndrome and but still qualifies for naltrexone, a week or two of gabapentin can make the difference in really getting on the medication or not.
Wow, that's so interesting.
Yeah.
Okay. And I guess the last thing, and you already spoke to this a little bit, but who is it that gabapentin is right for?
Well, again, as I said, I think it's really right for someone with a big anxiety problem, right? And I think that's the first level of right for us. And second, someone with insomnia, has sleep disturbances for whatever reason. So I think those two populations of people are just, I like, sometimes patients will hear, they'll ask if they're anxious and they say no, and I'm like, oh shit, too bad. Because I just lost but I think it's a great first line drug for those populations. I think it's a great second line drug for everybody. The big complication of gabapentin is that people feel kind of wasted and drawn out in the morning. They feel drugged and zombieized. Some people have said, like in the morning, and that seems to be a problem with many of our drugs. The other problem with the other interesting issue with gabapentin as opposed to naltrexone is that it can take a month or two to decide whether you've really got a response to gabapentin. So even though with the name, the words GABA is in there, it actually doesn't do anything to the GABAergic system, right?
In the brain.
Of your brain. There's no GABA of gabapentin. It actually acts on something called voltage-gated calcium channels, which is and we think it works by changing the way that neurons touch each other and make synapses. We think that's the current. When I say we, by the way, that's not me. That's the we of the scientists, right? Right. I haven't done this research myself, so we more as a they think, but we think that naltrexone works by allowing synaptic remodeling to occur.
You mean gabapentin?
Gabapentin, I'm sorry. We think that gabapentin works by allowing synaptic remodeling to occur, and therefore, it may take a while. Like if you're going to remodel your kitchen, it's not going to happen in a night. You're going to have to tear some things out, put some things in. There's going to be some inconvenience, which is kind of the lethargic feeling, and the other adverse effects may actually be proof that the medication is working.
Interesting.
Yeah.
So when you prescribe it, you give your patients a certain amount of time to really see if it's taking effect.
Yeah. This is one. If we start it, we don't want to look under the hood again for about a month.
Okay.
We want them to breathalyze and see everything and follow, but I'm not going to be deterred if they tell me at 21 days that there's been no change.
Okay.
It takes longer than that to get a response.
Okay. And one last thing, I know you mentioned these effects that might come from it. Do they go away, or how do members cope with it if they're on it for a long period of time?
They tend to go away. They tend to go away. Most people find that they go away. And we also do we move the dose timing around, sometimes earlier, sometimes later. We try to find an interval that works for people.
Okay.
So long as I can get to 900 to 1800 milligrams a day in people, that's my target doses, and I'm happy if I get to those points. And I don't really care how they, if they take 300 6 times a day, or they take 600 3 times a day, or 600 twice a day. I'm happy with that, or 900 all at once at bedtime. I'm happy with any of those, so long as I'm seeing some effect of the medication over time. I'm happy with dosing regimens.
Okay, great. That's really helpful. Thank you so much for taking time to be with us today and talk more about gabapentin.
It's a pleasure. Okay.
Bye.
Bye-bye.